Hello, or hola, mi hermanos y hermanas. It's Dr. Rutledge. I'm going to talk a little bit about the mini gastric bypass, technical points, backgrounds, and some other details. So I'm going to share my screen now. And so I'm excited about being invited to speak. I started off with a picture of my invitations and travel around the world teaching the mini gastric bypass, and I'm open for an invitation to Argentina. But it's been exciting 23 years since the first MGB was performed by me, and I'll talk a little bit about that. And it's been an uphill battle. The MGB has been kind of the weak sister of bariatric surgery, but I think you'll see in our presentation today that the MGB is growing like a young man growing into his adulthood. And so I hope I can give you some insights into the surgery itself, and maybe give you some advice on whether you should consider it, and if you want to consider it, some of the things to improve the safety for yourself and for your patients. So with that, again, my thanks, and I'll go ahead and start. Just a reminder for those of you who are a little bit new, the mini gastric bypass is nothing. There's no such thing as a mini gastric bypass. Basically, it's just a standard general surgery. It's an old-timey antrectomy and Billroth 2 gastrojejunostomy. It includes the equivalent of a collis gastroplasty, and a collis gastroplasty, of course, is nothing special. In particular, it's not obstructive. The MGB is restrictive, and we'll talk about that if there's questions, but it's not obstructive. So it's not like a lap band, it's not like a sleeve, and it's not like a Roux-en-Y pouch. The bypass is an anticolic Billroth 2, and that again is significantly different than the Roux-en-Y, and uniquely amongst all of the bariatric surgeries that I can see these days, it is tailored to the individual patient if you follow the original technique that I developed. The particular components of the original technique, as I see it, is it's very simple to perform in comparison to some of the other operations. It's rapid and allows a rapid recovery. And just as a reminder, many years ago when I was doing the first MGBs and they were a 30, 40-minute operation, I was bitterly criticized, saying I was being cavalier and doing it that quickly. And I think I was one of the first surgeons to do outpatient, same-day surgery and rapid discharge after the MGB. Again, I received a good deal of criticism over that. I believe personally it's a very elegant approach because the mechanism of action is different than the roadblock obstruction of a sleeve or a band or the vertical banded gastroplasty. And it's not malabsorptive, if you understand it correctly, like a distal bypass, like a biliopancreatic diversion. It's very effective. In most studies, it's the most effective or equal to any of the other operations. It's durable. You can go on my Facebook page and talk openly to patients who are 10, 15, or greater than 20 years after the first MGB. And that's a relatively unique situation in the world of bariatric surgery, as those of you listening will know. As I say, it's quite powerful and uniquely can be tailored to the individual patient. So a severe or significant diabetic who is of normal weight can have a modified MGB, along with obese, super obese, and super obese. Also uniquely, the MGB is almost trivially easy to reverse and to revise. So for all those reasons, I feel it's a very good choice, and I'll talk more about it. I have been bitterly criticized for the past 23 years and continue to be criticized, so I've gotten a bit of a thick skin. But as I said, my first several thousand patients, the mean operating time was 46 minutes, and that was derided and attacked and criticized. They said the hospital stay that I instituted of 1 or 2 days was too short. I was told you needed to take out the gallbladder. Many of you are too young to remember that, but that was a thing many years ago. Probably most of you don't remember that the initial Roux-en-Y gastric bypass done laparoscopically by Whitgrove and Clark was supposed to be retrocolic and retrogastric. and we pulled an EE anvil down through the mouth to the esophagus. So it was a quite challenging procedure. And mine was criticized because it wasn't done that way. They said that the MGB is the old Mason gastric bypass, and they predicted crippling bile reflux. And that's not been the case in those people performing it using my technique. And they said the Billroth-2 will lead to untold numbers of cancers, and that's not occurred. The pouch and the gastrojejunostomy were bitterly criticized because they were obviously too big and the patients would not lose weight. And so my critics were wrong about that. And interestingly, I was criticized for using something called email and because I had a website. I hope you'll find the amusement in those things as I do. So the past is well known. I've had a great deal of criticism. Fortunately, particularly the surgeons in India have stood fast beside me as both brothers and sisters in arms. We've seen the lap band, for example, come and go in India and around the world. And it seems like even the United States may catch up, as well as other changes in bariatric surgery, and there are some good and some bad. MGB surgeons have in general stood as a group. We've been unified, studying and publishing our results in the face of pretty significant criticism, but with the support of our patients, seeing their good results and good outcomes. So I've been proud to be part of that effort. What we have known for more than 20 years has now been recognized by IFSO that the MGB's good outcomes are led to the birth of a new procedure. And what we say is, although we're happy with that, the game is not over. And we'll talk about some of the particular concerns that remain with the surgeons performing the MGB who are untrained or using theories of approach that do not match the MGB. So the future we think is filled with great promise, and we'll give you some examples of the developments in MGB, but also there's significant danger. For example, the Y-omega trials and others where we say relatively untrained, biased, or confused surgeons perform the MGB badly, leading to complications and death. And so we're happy about the growth of the MGB around the world. In India, it's been on fire, but also the Middle East, Europe, really around the world, except for America, the MGB is growing to be a very prominent part of bariatric surgery. The point that we'll be emphasizing about the future is that the MGB done wrong can result in devastating complications and even death. It's an easy operation, but you have to change your mind and undo some of your analogies and understandings that you've had in the past, in my opinion. Misunderstanding of the MGB, and we'll only show you a few examples of that, has left severe problems, complications, and even death in attempted MGBs by surgeons who have their own ideas, invented their own versions, and resulted in complications and, as I say, tragic deaths of unnecessary events in patients. Common errors that I see when patients or surgeons consult me is a short pouch, a twisted pouch, a bird's beak defect of the pouch, a narrow pouch, a stricture of the pouch, dissection of the EG junction, a BP limb that's too long, a BP limb that's too short, strictures at the gastrojejunostomy because of the performance of the procedure, kinked or tight gastrojejunostomy, a reversed BP limb is more common than you might imagine, ischemic foreign body, and many more. And we'll talk a little bit about some of these. So as an old surgeon, I give advice to the surgeons I used to teach, and I say, beware of brave surgeons. New and old surgeons need to understand the procedure and how it's done. And then, of course, if they wish to innovate, they may, but only with caution and careful follow-up. How to avoid trouble needs to be understood, and then how to get out of trouble. And what we see is around the world, there are many surgeons who do not fulfill these guidelines. I like to quote this saying, with great power comes great responsibility. The MGB is a simple, powerful operation, but it must be used responsibly. Anyone can do a single anastomosis. It doesn't make it the mini gastric bypass performed by the original technique. And while I have dozens, maybe even hundreds of examples, I'll just show you one. This is from a French series, which is emblematic of, for example, the Y-omega trial. But in this case, they found 17% gastrojejunostomy strictures in the MGB. Well, my bias is that's not an MGB because we don't see those strictures. So the MGB can be painted as bad if it's done badly. This is an example of a badly done surgery, not of a bad MGB. It's an operation done badly, misunderstanding an MGB and how it should be done. So we think there's great promise, but also danger, and I'll address that subsequently as we go through this, the past, the present, and future of the MGB. Just a reminder that most bariatric surgery up until today have come and gone. This is the lap band, and here's the lap band comparing to the new heights that we're seeing the MGB taking off at. Here's just some, I think, signal examples of the MGB and its, I would say, really salutary results. This is some data from my friend, Dr. Kular, 10 years of follow-up after MGB. The hemoglobin A1C was less than 7 and 96% of those long-term patients. Here's the data pre-op 9.1, post-op 5.8. The maximum 7.6. So basically what we see in this series is close to 100% cure at 10 years for MGB of diabetes. Again, there's a lot of controversy on this. I think our data clearly shows that done in the technique of what we call the original technique, that we can tailor the BP limb and that the dosage of MGB is unique because as we tailor the MGB, the delta of hemoglobin A1C goes up. So the longer the bypass, the greater the decline in hemoglobin A1C. So we can offer our patients more or less power based on what they need for diabetic control. Now let's look around the rest of the world to give you some more background while we get into more detail. This is from the Israeli National Bariatric Surgery Registry, 5-year analysis published in 2020 last year. And basically, the MGB was not done in 2014. In Israel, very few MGBs in 2014. Over 4 years, almost half of all surgery done for bariatrics in Israel was now done as an MGB. And the sleeve, which was 80% in 2014, is now down to 37%, a decline of nearly or over 50%. Why? Why was this decline in sleeve so precipitous? And why did suddenly MGB become the premier choice in bariatric surgery in Israel? In fact, if we project those numbers, there'll be no more sleeves and all the operations will be MGB if there's no change in that trajectory. But why? Why did this happen? Well, it's hard to hide failure in a small country. What if 1 out of every 3 of your patients failed? So this is data on almost 10,000 patients from India. And what they showed is they looked at the rate of postoperative weight regain. And the rate in sleeve was 1/3. In other words, 1 out of 3 gained their weight back. And for MGB, 3%. That is, the MGB was 10 times better than the sleeve. I think we could stop the presentation here. But here's the paradox. The MGB born in controversy, and there have been questions about bile reflux. Some have published results saying it's common in their series, while my series and surgeons who you saw on that map who trained with me find that it's quite rare. There's also reports of excessive weight loss and that revision is common. In the Y omega trial, a very high percentage needed revision of their MGB in the first year. Yet these surgeons also reported that all they did for learning the MGB was read 1 paragraph in an article written by me over 20 years ago. That's their total training on MGB. Whereas if you look at those of us who've trained carefully on the MGB and learned the MGB, excessive weight loss is quite rare and easily managed. Marginal ulcer, deficiencies, malabsorption, these and other problems are the paradox of MGB. Excellent results versus terrible results, MGB original technique versus someone who just read a little bit and started doing it, and they're surprised by having trouble. Here's another example. Reflux is very common. Even in people who don't have surgery, up to a third of Americans have been reported to have reflux without bariatric surgery. And there are criticisms and complaints about reflux after MGB. Yet, for example, studies by Dr. Lee, Kular, and myself of more than 1,000 patients, reflux complications leading to surgery is less than 1 or 2%. But again, a recent Australian series where I assume the majority have not been trained in the original technique, 1 out of 10, up to 10 times as much reflux additional surgery. Now, why? Well, it could be that the reporting is wrong by us, the bariatric surgeons who've done the MGB. Maybe we're wrong, we're missing it, it's not being diagnosed, or maybe they're wrong and it's being overdiagnosed. So it could be inaccurate reporting. But the other thing I ask for you to consider is maybe they don't know what they're doing. Maybe they're doing it wrong. Maybe they're doing it the way they do Roux-en-Y and sleeve, and maybe that's the reason. But this, I think, is the problem. This is the paradox of the future of MGB. Don't do an MGB, I request, if you don't know what you're doing. Okay, I'm going to give you a little bit of background. Where did this all start? And my background, I was a trauma surgeon for 20 years and a professor of surgery at the University of North Carolina in Chapel Hill, North Carolina. And I was one of the first surgeons to perform laparoscopic Roux-en-Y, and it was very difficult. I won't go into details, but it was quite a challenging procedure, and not being critical of my friends, often it would take them 4 to 6 hours to do a Roux-en-Y laparoscopic gastric bypass. During my regular work as a trauma surgeon in 1997, I was asked to come to the ER to see a person who was shot in the abdomen 6 times after dealing drugs. His customer had a disagreement with him over pricing, and he had 6 gunshot wounds to the abdomen by a .357 Magnum size bullets. 9 o'clock that night on a Thursday night in September 1997, I took him for emergency surgery, and he had numerous bullet wounds to the stomach, the tail of the pancreas, and multiple loops of small bowel. To treat him, I did numerous small bowel resections and repair, but also, most importantly for our talk today, I did a distal gastrectomy, a distal pancreatectomy, and splenectomy. And that was all done open. And I repaired them using standard general surgery, okay? A standard general surgical procedure. I did a reconstruction with a Billroth 2 gastrojejunostomy. And the next morning, I had one of these very challenging Roux-en-Ys, and I thought to myself, why am I going retrocolic? Why am I doing all these other things that Roux-en-Y surgeons say I must, when I could do what I just did a few hours before and work very smoothly to deal with a very difficult patient? And so that morning, the very first MGB was performed, and basically it was a callus gastroplasty with a loop gastrojejunostomy. And the very first MGBs were 100 centimeter bypass. So the MGB is nothing special. I like to emphasize that to my trainees. The MGB is a Billroth 2, routine general surgery. It's not a trick, but many surgeons are doing the MGB, and they're not doing it as an MGB as if it was a general surgical case. They start thinking sleeve and band and Roux-en-Y, and I think that leads to problems. The Billroth 2, for example, many bariatric surgeons I find don't understand is actually a good, safe operation. And I refer to the research from Taiwan, which showed in 3 large-scale studies of more than 6,000 Billroth 2 patients who had had their Billroth 2 for peptic ulcer disease, that in a matched comparison with 20,000 plus other peptic ulcer patients who were the same age, sex, race, and other comorbidities, that the Billroth 2 patients had better survival, better rates of heart attack, stroke, and diabetes. That is, the Billroth 2 makes you better in comparable patients. Billroth 2 patients are healthier than similar patients without a Billroth 2. It's good for you. unless it's done wrong. General surgeons know how to use the Billroth 2, and many bariatric surgeons are confused, uninformed, or fear the Billroth 2. Well, why are we here and what's this all about? And what can I tell you today? I want you to think of this warning that the MGB can be a superb surgery. There are now hundreds of papers showing in skilled hands, the MGB can be excellent. But we also have data to suggest that incompetent, uneducated, or biased surgeons doing an operation which they're not adequately trained for, there are tricks and traps. But that's true of every surgical procedure. Starting an intravenous line, starting a subclavian line, intubation, placing the ports for laparoscopic surgery. All of these can be done badly if you don't know what you're doing. Here's what my data shows on a survey of several hundred surgeons who volunteered to do a survey. Those who had low volume had poorer outcomes, more leaks, more reflux, more revisions, more like their old loop and their description of their loop, and less like antrectomy and Billroth 2. Those people who do the operation badly have bad results. Okay. Now, I mentioned one other thing is, if I tell you the MGB is good, I think you could be skeptical because I have a personal stake in the mini gastric bypass. But there is something new that I would mention just briefly, and I'll go through a few of these just quickly. And that is the opportunity to talk directly with patients who've been operated by me 10, 15, or 20 years ago. That is, you can go to Facebook and go to the various several thousand people who've had MGBs by me or other surgeons who use the original technique and talk to individual patients, ask them how they're doing. Similarly, you can also talk to sleeve patients and Roux-en-Y patients, and I recommend you do both of those things if you want to see good results. So join us if you wish. You can talk to thousands of MGB patients because the MGB appears, in my experience, with 10, 15, and 20-year follow-up to be an excellent operation. So these are some examples. I can't believe it's been 20 years. I was 300, I lost 150, 18 years post-op, 20 years post-op, 2003, 328 to 124, 11 years ago. On the other hand, there is a Facebook group called Weight Loss Surgery Ruined My Life. And I recommend that if you want to see the result of sleeves, Roux-en-Y, and lap band patients, and look and see if you can find an MGB patient. And if you find one who has trouble, please refer. I'm happy to try and help. That is to say, you can look at patients easily today of who had the MGB and who've had sleeve, Roux-en-Y, and lap band. Now, here's some survey results on my patients. And we've classified in one particular analysis results as the patient saying, poor, I lost too little weight, I lost some weight, I lost a lot of weight, or I lost all the weight I hoped for, I lost too much weight. And basically, you'll see here gray, this is good, I lost a lot of weight in 50%, and the other 40% is perfect, I lost all the weight I hoped for. And then fair, and then 1.6 and 1.9% had either too much or too little weight loss. This is that same data here. The other thing I would say is I do get calls from surgeons and patients all around the world, and I offer myself to you and my friends in Argentina. If you wish, call me anytime. I'm happy to discuss technical issues of the surgery, but also post-op diet history and problems. Please feel free. Call me anytime, or the patient, you can refer them to me. I'd be happy to talk to them, and there's no charge for this. Same thing again. Recently, 2 MGB deaths. 2 surgeons called me recently after MGB death. Is the MGB dangerous and deadly, or do you need to learn an operation and how to manage it before you offer the procedure? Bile reflux, I'm going to leave for another day, But please feel free to contact me and discuss it. Bile reflux is generally a technical error by the surgeon or a dietary and management error by the patient, usually are easily revised or reversed by simply changing a few things in your surgical technique and or talking with the patient and managing differently. All right, now I'm going to skip forward to the surgery itself. And these are some of my visits around the world. I think it's worth mentioning briefly before we do the surgery is the goals of bariatric surgery. You want low risk, MGB, major weight loss, MGB, easily performed, short operative time, outpatient or short hospital stay, minimal blood loss, no ICU, minimal pain, a good exit strategy, and we'll talk a little bit about that. Changes behavior and preferences with the dumping syndrome, minimal retching and vomiting, not like the sleeve and the band, few adhesions or hernia, minimal impact, low failure rate, low cost, short recovery time, etc. The MGB essentially, in my opinion, meets all of these 30 criteria that I developed looking for what would make an ideal operation. Okay, so these are the ports that I use. You can use other ports, but I won't go into detail, but I see a lot of people operating between the legs and port sites placed lower and a lot of confusion with liver retraction, but I'll leave that out for today. But we begin simply by dissecting the lesser curvature just at or below the crow's foot. Then we want the staple gun to come in from the subxiphoid, and we want it to be perpendicular to the lesser curvature at the beginning of the antrum. Now we see a lot of errors where people bring the staple gun in from below, and then they get what's called a bird's beak defect. We'll talk about that a little bit later if you wish. So this is where we want. And now what we want to do is we want to create a big, wide tip of the pouch. And this is that bird's beak error. We see a lot of Roux-en-Y surgeons and sleeve surgeons, and they start to make the staple line here. But instead, what we want is this way over here and way up here, and then come back. Now, and this is what's called the cobra head here, because we want a wide open gastrojejunostomy, the cobra head. And then we're going to come up here. Remember, we've got this wide base, come up here and stay away from EG junction. And it's not a sleeve pouch, and we don't want this narrow. We want it so it's basically the equivalent of the esophagus. And this is that cobra head. And we don't need to dissect the EG junction. Stay away from the EG junction. So this is cobra head, and this is stay away from EG junction. That's why we never get leaks. Because where do most leaks come from? They just come from dissecting the EG junction near the esophagus, and they're a deadly long-term complication. We don't have them because we don't go there. Now we're going to create our gastrojejunostomy, and we remind you again, don't go near the EG junction. We do an anterior gastrotomy here above, and then we run the bowel. And now we have these two. Staple gun comes in from the midline, parallel to the long axis of the body. And again, the staple line goes through the staple line here. That splits it open and makes this all a healthy, maximum vascularized area. And then we close that, and that's it. So that's basically our presentation. I'll go ahead and stop there. We'll send you copies of these slides plus another additional 150 slides on more details, taking up more time than I have for this morning. I'll be happy to answer questions, and I have slides and videos I'll be happy to offer as well, and you'll have a PDF of these slides in addition. Thanks very much for the invitation, and go ahead and once again, thanks for this invitation, and I'll send you those additional educational materials. Thank you.